Good morning. Thank you for joining us for our KHC office hour today. It's always great to be with you. Today is Wednesday, March 23rd, 2022. This monthly series is predominantly in support of Kansas hospitals, particularly those participating in the Compass H-Quick, yet all are invited. We welcome everyone who has taken the time from your busy day to be with us this morning. We've prepared a handout for you of today's presentation. A link was included in your Zoom webinar reminder this morning. We've also placed it in the chat for you. For sound quality, everyone is muted other than the speakers. We do have the ability to unmute our lines later in the hour if needed. This session is being recorded. We should have a link posted to our KHC Education Archive later this afternoon. We're pleased to use our Zoom webinar platform for this virtual session. We encourage you to locate the chat and the Q&A features on your screen. Please use the chat feature to let us know where you're joining us from and to add any comments or discussion. When using the chat, please select all panelists and attendees so everyone can see your message, not just the panelists or speakers. If your message is only for the presenters, go ahead and select all panelist option. The Q&A feature has a special role too. Let us use this feature to pose any questions to the presenters. I believe that only the presenters can see your questions that are typed in. We can either field your questions during the live Q&A time, or we can respond in writing. Let us begin with a message in the chat. Go ahead and select all panelists and attendees from the drop-down menu and let us know where you're joining us from this morning. Go ahead to the next slide. So here's an outline for our time together. We're pleased that Rhonda Spellmeyer from the Kansas Health Information Network, KHIN, is joining us this morning. Rhonda's going to spend some time showing us how to use the KHIN dashboard to help drive our readmission reduction and increase our care transitions in our hospitals. Eric will join us later in the hour and give us some Compass H-Quick data updates. And then as always, we'll share some resources, upcoming events, and next steps for you guys. Just a reminder, if there are any questions, please type them in the chat or reach out to any of us at any time following this office hours. Next slide. Your KHC Compass H-Quick team with you today include Erica Queens, our data director, Heidi Corson, quality improvement advisor, Patty Thompson, and of course myself, Erin McGuire. We do also have Rhonda with us. Next slide. I do want to give a last call to our H-Quick hospitals as well as our community mental health centers to participate in our Align All Health initiative. Kansas hospitals that are in the Compass H-Quick and have their KHIN dashboard technology in place, this is your last chance to participate in this initiative. The KHIN and KHC team are working to provide a targeted intervention through June of 2022 for our hospitals and community mental health centers to help improve health outcomes and care transitions for high-risk patients with behavioral health needs. Hospitals and community mental health centers will receive a $1,000 stipend upon their successful participation. If you are interested, please reach out to your QIA as soon as possible for enrollment. Next slide. So at this time, I am pleased to introduce you to our guest, Rhonda Spellmeyer. Rhonda earned a BSN in 1996 and has been an RN for nearly 25 years, working in critical access health systems in various roles. Those roles have included bedside nursing, in med-surg, ER, OB, outpatient, cardiopulmonary rehab, swing bed, and case management. Additionally, Rhonda has served as a nurse manager, clinical IT analyst, and chief nursing officer. Ultimately, Rhonda found herself earning an MBA and focusing on bridging the gap between clinicians and health IT in hopes of improving not only patient care, but clinician and patient satisfaction. Rhonda has been actively involved in many successful quality improvement initiatives throughout her career with a recurrent theme of workflow analysis and the impact it has on outcome success. We're very excited that Rhonda is here to share her expertise with us. Thanks for being with us today, Rhonda.
Thanks, Erin, and thanks everyone for joining us today. When you gave me that introduction, it just sounded so fabulous. I want to know me as well. No, I'm just kidding. We're going to go ahead and get started on our discussion. And most of you I have probably worked with or chatted with or emailed with at some point regarding health information exchange and interoperability. So We're just going to go ahead and dive on in. Next slide, please. I like to give just a little bit of an agenda talking about just what is interoperability, what I have found over working with organizations, and especially specifically with our hospitals and clinics and CMHCs, is that not all of our healthcare staff and our clinicians really fully comprehend the extent of interoperability and what it can do to improve organizational and patient outcomes. Without understanding this, there can be a hesitancy in adopting health IT, specifically health information exchange in their regular workflows. In my discussions with folks across Kansas and also the nation, as KHIN is a nationwide HIE, it's not uncommon for folks to be completely unaware that HIE exists and that their own electronic health record is connected to a health information exchange and what its purpose is. So before we really start diving into specific use cases and workflows using our interoperability tools, I wanted to just kind of review some basic HIE information that everyone needs to know. What I have found is the more we are exposed to this, the more we discuss it, the more we hear these words, the more common they become in our daily workflows. Next slide, please. So what is interoperability? What is KHIN? What is health information exchange? Most of us working in healthcare, especially before electronic health records, will recall when we first implemented our first EHR and began with health IT, and that was for meaningful use. We got paid to implement and utilize our electronic health record systems. It wasn't necessarily a welcome change for everyone, nor was it without a lot of lessons learned. KHIN was created as a result of the Federal High-Tech Act of 2008 to help promote interoperability. And so I know as a staff nurse at that time, when we had to, we started using electronic health records, it was very challenging, and I didn't always understand the big picture, which was ultimately to be able to share data, patient data, and other information electronically in a more secure, more efficient format that ultimately can lead to better outcomes. KHIN itself is a nonprofit organization. We're physician-led and associated with the Kansas Medical Society. We're rooted right here in Kansas. As I mentioned before, we are nationwide. We've expanded to 9 other states in the US, but Kansas remains one of the most connected states. And it's amazing to me when we work in other states, when I work in other states, how kind of behind some of those states are with connectivity, whereas in Kansas, we have just under 100% of hospitals sending data to our health information exchange, and probably around 65 to 70% of clinics are sending some kind of data as well. That is really kudos to our forethought with our legislature and with our our leadership, KHA and all those other organizations that have really propped up interoperability in the state. There's a lot of different types of HIEs. You've probably heard of ones that are specific to your particular electronic health record, that you can share data with organizations that have that same record. There are some for large health systems. So you'll see these nationwide health systems that have tied all of their records together in their own HIE. And then there are the ones like KHIN. We're regional, we're agnostic. We don't care who you are. We don't care what your EHR is. We just want to have you send us your data so we can utilize that and help advance patient care. That's really the crux of everything we're trying to accomplish. With that being said, though, KHIN is also able to connect with other health information exchange via a national hub. So you're not limited to only providers that send us data directly. HIE may seem like an abstract term, but it serves to connect provider data points. So the information that we fax, we hand carry, even mailed, can now be viewed at the point of care electronically. So, really the definitions are here, but, interoperability is essentially the ability of 2 or more systems to exchange health information and then use the information once it's received. And that's the key right there. Next slide, please. So why do we even need interoperability? I mean, if I can send a fax, if I can, chart on a piece of paper and fax it to someone else, if I can mail it, if I can hand carry it, why do we need all this interoperability? Well, really, there's several reasons. Of course, first of all, and most of us will agree if you've worked in any kind of healthcare setting, especially in an administrative or quality role, we have regulatory requirements. And those regulatory requirements really focused on hospitals and initially in clinics, but we are seeing them actually translate to other care settings as well, like community mental health centers. Community mental health centers are going to be required to be interoperable to send their data to an HIE as part of their CCBHC requirement. We'll get into all the weeds on that, but it's a federal designation. And as we all know, we really have been striving in Kansas to improve our mental health services, and that's just one component. Hospitals have what used to be meaningful use. Now it's promoting interoperability. Clinics also may fall under promoting interoperability or MIPS. We also have payer requirements, and there are certain payers, commercial payers, Medicaid, MCOs that require some sort of interoperability as well, and provide incentives or penalties based on that. Now, of course, we all, regulations, we all have to focus on that. But ultimately, as a nurse and as care providers, our main goal is better outcomes for our patients. We really can, see as, evidence-based practice that interoperability does improve those outcomes. We can increase care transition support and reduce readmissions, which we're going to talk about shortly. We can utilize interoperability to just make more appropriate care decisions. When you have more and better and clearer information for your patient, then you can make a better plan of care for them. We also can have improved clinician satisfaction. Believe it or not, electronically sharing data can, if utilized correctly and effectively, can improve and does improve clinician satisfaction. And then ultimately, too, we have patient portals that exist as a result of our electronic health records, so patients can log in and they can actually be empowered and they can have more stake in their own health care. And then, of course, financially and operationally, we can improve efficiency. We can reduce workload of finding outside records and sending records to another provider. We can reduce cost and related to readmissions. We can improve the quality of our coding and our billing. These are all things that are absolutely supported by utilizing health information exchange. And you'll see here, I do have some links. These are just the ones that are specific to regulations in case you were interested. There are some really cool updates, and I have mentioned those before as far as bidirectional interfaces. That is an optional measure. And if you need more information about that as a hospital or a clinic, feel free to reach out to me and I'll let you know if KHIN is able to assist you with that. Next slide, please. As I mentioned before, evidence-based practice is kind of my heart and soul there, because I do think it's really important to not just have anecdotal evidence showing that an intervention or a technology or a workflow seems to be good and have good outcomes. I think it's really important that we can actually support that with evidence. So with that being said, this is one of my favorite studies. I just absolutely love this. It's from the National Institutes of Health. But this is basically just showing you if the impact of viewing medical history in an emergency room. And so when you see this, I absolutely love this. On the left-hand side, readmissions within 7 days. We can actually reduce those readmissions in this particular study. All differential diagnoses, regardless of what the patient presented with, they were able to reduce those readmissions by 56%. Just by utilizing more, better, and clear information. So when that patient came in and we thought they had they've got a low hemoglobin, they're coming in, their hemoglobin's 8. Well, it might have been 7.5 the other day, so that's actually an improvement. You know, so there's some really great opportunities there. And then you'll see also on the single day admissions, and this would really kind of hit home to me because I know in my experiences in a critical access hospital where your staffing is limited sometimes, and you don't always have you know, the resources to admit and dismiss somebody within a day. You know, the single day admissions were reduced tremendously. We all know how much time it takes to do an admission, including those assessments, med reconciliations, all of those things. If that patient truly did not need to be admitted, we are saving that nurse and that other staff a lot of time and effort and energy that they can then put into other patients who do require more attention. I did also want to mention that during the care continuum process, use of HIE reduces the time spent gathering data by 42%. That's time you can spend doing a lot of other things. And I know for me as a nurse, you know, back in the day, somebody might call me, I'm working night shift and they need information because they've got a patient in their ER and they need me to send that information, but I'm also providing patient care. It would be, you know, behoove everyone if that person could just access the portal and then, you know, we can actually streamline that. Additionally, when a clinician uses HIE, the workup or the treatment plan for that patient is altered approximately 42% of the time. So what that tells me is by not having complete data, we may not always be providing or creating the most effective treatment plan for that patient. Also, when you do use HIE effectively in the emergency room, and we actually worked on this with a large facility in central Kansas, and it was just amazing the results we had. But from the time of presentation to the ER to disposition decision, so they present to the ER, and by the time we decide what we're going to do with them, discharge, transfer, or admit, we can reduce that time by 50% by having some of that information. On top of that, we can reduce lab, you know, repeated lab or a redundant lab, redundant CTs, redundant x-rays, that kind of thing. So HIE can actually really help conserve those really rare resources that we have, especially in our smaller community hospitals. Next slide. How does interoperability work? The reason why I have this on here is because I think it's really important for you just to get a very basic overview of what is all this, because I do run into a lot of folks who get a little confused about the tools we offer. And I think understanding where that comes from and how it works in that flow, even at a basic level, can help you understand our tools and then ultimately how to apply them. Y'all have an electronic health record, be it, you know, Cerner, Meditech, ECW, Epic, you know, any number of those, even behavioral health, those are they're getting more robust electronic health records as well. That EHR has an interface that comes to us. And, you know, obviously interfaces, it's more complicated than that. But when we receive that data, we then can organize that data at KHIN. And we do that in a couple of different ways, or several different ways. But we can organize it so that you can look at a patient's chart individually, and we organize it so that you can look at more of an aggregated view and analytics view. And we're going to talk about that here shortly. But when you want to access the data that KHIN is organizing and holds in the repository, you can access it in several different ways, depending on what your needs are. First and foremost, and everyone that is a member of KHIN has the ability to access the KHIN web portal. That's just that very simple, go to our webpage, log in, and look up a single patient, and then look at their information. You may also have the capability of looking at KHIN data or health information exchange data within your electronic health record. And that's where that bidirectional interface comes in. When we've talked about receiving a CCD and reconciling meds, allergies, problems, and procedures, that's because of a bidirectional interface. Not everybody has those, and that's okay. But if you do, then that just saves you a login to another system. Other access includes our HQ Insight dashboard, and that's that analytics dashboard that most of you have gained access to within this past year, especially through that HQuick quality program. Lots of data in there, and so it can be a little overwhelming, and we're going to touch on that here shortly. There's also the ability to do participate with secure direct messaging, and that is through our KHIN portal. A lot of electronic health records do have secure direct messaging available within your own electronic health record. Some do and some do not. Some have it, but maybe it's cost prohibitive to use it, or you just need a generic email, what have you. Secure direct messaging is really the ideal way to send protected health information from point A to point B if you're doing maybe a referral, or a collaboration on a patient, or follow up on a referral, that kind of thing, because it meets certain criteria for security and privacy. And then the other access is for the patient. We do have a patient portal available that patients can sign up for and then view the data that comes into KHIN from all of their providers, if those providers are providing that data. Next slide, please. So our KHIN tools really focus on two things. First is that web-based portal or within the EHR. And as you can see, my computer still thinks I mean her when I mean electronic health record. Spell check is not always my friend. The great thing about the portal is it can be accessed at the point of care. You can have many users in many different situations. You can also take those records that are within the portal and export them. Or print them to paper if that's what your workflow demands, and you can include those in your electronic health record, which you should be doing if care decisions are made based off of data that's found in the HIE. You can review continuity of care documents, notes, meds, allergies, all hosts of things, and visits that patients have had at other care providers who are sending data. And then really the goal of all of this is following up on things, transfers, following up care transitions, infection control. During COVID, we really saw a huge increase in usage from infection control practitioners, looking for their labs, looking for, follow up on those SSIs, if somebody's transferred, that kind of thing. Instead of having to call all over creation, trying to figure out where I can get this lab, it may very well exist in KHIN and you can get that at your own convenience. The other tool is Health Query Insight, or HQ Insight. That is our dashboard, and that is that analytics tool that depends essentially on the information in KHIN. So the web portal receives all of this individual information, and it's available for point of care use to look at patient, medical records. But then we take it one step further, and we move that data into our dashboard. And what is really great about it is it's web-based. Again, you don't have to download specific software for that to work. You can typically, it's accessed outside the point of care, which means it's not really intended for use for a nurse in the ER, or it's something that you would use in real time. It's more for directing resources. But it also helps support your quality metrics and programs, which we have been working on with HQuick. We can create patient panels to assign resources, so we can identify a group of patients that maybe needs more focus in a certain area, like diabetics. And then my favorite functionality is the notification of ED or inpatient admissions. So as you can see, we've got those two tools. The HQ Insight dashboard relies upon the data that is in KHIN for aggregation and analytics. Next slide, please. All right, so there's any number of ways that the portal can be used and numbers of workflows, and I really just want to focus on getting you to think about how you could use the portal, the web portal, to look up patient information and why you might want to do that, who you think should have or who should have access to that, and some tips and tricks to keep in mind when you're actually utilizing this. All KHIN organizations, any organization that is participating with us has a KHIN membership, has access to the provider portal, and it's based on individuals. Those logins have to be created, requested, and created. And what I found is that most staff, especially those at the point of care, have no clue that they could potentially have access to this tool. If they do, they may have looked at it years ago and didn't find it useful. I'll be honest, I was one of those nurses, 5, 6 years ago. We were still working on getting organizations to participate. So, the information may not have always been consistent, but at this point, like I mentioned with the connectivity in Kansas, we have a lot of data in there. And we are also in the process of connecting to the Nebraska HIE. So we will have that information from them. And then we also are connecting, or we are connected in Missouri. We have a little bit of connectivity on Eastern Colorado, and then working on Arkansas. Well, actually, we do have a connectivity in Arkansas, and then we're working on Oklahoma. We're not as far with that one as we are with the others. But, with the increasing interoperability initiatives, the data is very robust and continues to really grow. I want to mention a few little tips and tricks for searching in the portal for those of you who do get in there. You'll find that patient matching is important. We require the big four: a last name, a first name, a date of birth, and sex. Now, with that being said, we highly, highly suggest that when you are searching for a patient, that if you have optional demographics to put in, go ahead and put those in, because it can make the search faster. I know sometimes that the searches can be slow compared to what you're used to maybe in your electronic health record. But you got to remember, there's millions and millions and millions of people or unique patient records in here. And so it can be a daunting task. So I recommend at least getting the patient's state, city, and zip code. There are some health information exchanges or some sites like KU that does require that extra optional demographics. So if you're wanting KU Med, Great Bend, which is a KU hospital, you definitely need to put that in. So just make a good practice of putting in optional demographics if you have those. And then some of you, or a lot of you I've talked with, I talk about that drop-down menu that gives you access to other health information exchanges like the VA and Department of Defense. When you're looking at that, you absolutely need optional demographics. And if you are wanting to look at a VA patient, the VA requires a social security number, which is not always available to end users. So just keep that in mind. You do absolutely have to have a social security number, but that VA information I've looked at is really good because it can be hard to get information requests from VA filled. Making sure that you know that you can export this data. So when you open, and you can see on the right hand side of the slide there's some different documents. Always check for the CCDs first, because those are going to be typically a summary of a visit or a summary of that patient's record at that organization. Look at that under the clinical history. And you can see those documents any window you open. If you go to the printer icon, you can export it to print it, or you can print it to a PDF, save it, and then upload it to your patient's record into your electronic health record as an attachment, which I think is very, very important. And if you can get away from scanning and whatnot, that's really ideal. But if you print it, then your HIM can scan it as well. Then after you've looked at the CCD, I would always then check the history tab and look at your visits and that other data that exists there to get a full picture of your patient. There are some really good use cases to put in play for this. I recommend to anyone, if you do not already have a pretty robust HIE interoperability plan for usage, that you start small. Start with one department, start with one focus, and making sure that you kind of get those kinks worked out before you put it into another area. A lot of organizations like to start in the emergency room, especially because looking at baseline results from other facilities. Lab is a huge one. A lot of us like to look up that lab that was elsewhere. So the ER, like I said, is really important place for that. And as I mentioned before, when we are utilizing our HIE in the ER, we're reducing readmissions, and we are reducing time for decision to disposition. And also, like I said, making better decisions, more efficient care decisions. You can use this to do a history an assessment. So, if you wanted at some point to have your, when you're doing an admission assessment on the floor, it can be very challenging. And if a patient's not real well known to you, or maybe they are well known to you, but they also seek care at other organizations, let's make sure that we've got all the information we need when we're doing this assessment. Problems and procedures, that's always a big challenge to keep updated, because the patient may not always be a very good historian. So I find that HIE is very, very useful for those poor historian patients. It's also really good for closing up those referral loops. So, if you're sending your patient to another organization, transferring them, if you referred them to a cardiologist, that kind of thing, at another facility, you can get in here and get that information. I know a lot of the larger facilities do fax or send notes, etc., but that may not happen in as timely of a manner as those notes are uploaded to Health Information Exchange. So it's just something to keep in mind. If you haven't received a note from a patient, log in, that you sent for a referral, you can log in here, get that, and then put it in your chart and have it provided for your provider. You can look at their visit list, and this is one that I really like. When you're doing those readmission risk assessments as part of HQuick, if you've implemented that, sometimes we don't know where all they've had their visits. That patient might say, yeah, I was at such and such for, whatever, but they may not have, they may be a poor historian, or they may not disclose every visit they've had. So you can look at that visit list and then make sure that you have an accurate data points for that readmission risk assessment, for determining how many visits or admissions they've had in a certain time frame that might increase their risk for readmission. There's other uses for HIE, including coding support, basic demographic information. I've gotten in here before to get just some demographic information on a patient that was seen in our ER, because most of us don't have 24-hour registration, and sometimes we are not able to always gather all the demographic info we needed. And then something else to think about, and that's down the road, and this really isn't care transitions or readmissions, but for disaster planning supplementation. This is a really great way to have a backup. It's not an entire backup of your records, but we have had a couple of hospitals that have had issues with their electronic health record where they couldn't access it. So they're able to use KHIN to actually at least see their own records while they were working on their electronic health record. It's also really good in situations where you may have a massive influx of patients because of maybe a trauma, MVAs, if there's a tornado, that kind of thing. So just think about that down the road, that's another use case. But ultimately, implementing Caroline and implementing the web portal in strategic places within your organization does help with care transitions, because you do get, you can access that information from another site. You can absolutely be aware of where they've received other care, and just helps you have a better picture of your patient. Next slide, please. And then, of course, we have the HQ Insight dashboard, and this is, there's so much information here, so it can be very easy to feel overwhelmed. Is at the top there, you can see those are what we call our tiles, and the big ones for really working on care transitions and readmissions are the acute alerts, the readmissions tile, and the high risk and polychronic tiles. And how do we use those? What do we do with those? So most of you that have spoken with me or that I've worked with will know that the acute alerts is that tile that gets updated in real time. That is based off of those admission, dismissal, transfer messages that when you register a patient. Remember back in June of last year, CMS said all hospitals have to start sending electronic notifications to relevant care providers if a patient has been admitted, discharged, transferred, ER, inpatient. Since the vast majority of hospitals in Kansas were already sending us ADT, we were able to meet that criteria for that condition of participation for all those sites. But what does that mean? What do you do with it? It's really an amazing tool for follow-up on care transitions. And, there's multiple uses for this. Some of you have heard me talk to you about using it for an internal alerting system. A lot of what we do in our critical access facilities, in our clinics, our hospitals and our clinics is we either, what I hear is we are manually sending a message. We are calling and leaving a message. We may fax that, oh, so-and-so was in the ER last night and they need a follow-up tomorrow. Or as happens a lot, we tell the patient to call the clinic and follow up. And many of our clinics are patient-centered medical homes. We can do transitional care management visits, but there are certain criteria that are required, which means you have to contact that patient within a certain amount of time after they've been discharged. Some patients simply, maybe they've come to the ER and they don't have a PCP. That's a great opportunity for your clinic to reach out and get them on as a patient to your organization. So, what I recommend is somebody at your clinic, if your clinic is affiliated with your hospital, which most of our cause, that's the case, they can have access to this. Having 1 or 2 nurses have access to your acute alerts to look at that and say, oh, Joe was in the ER last night. I'm gonna go check the EHR and see what he had done. Oh, he's got CHF. We need to get him called today, make sure he's getting his meds, make sure he's, gets his follow-up, understands his weights, etc. So that's an internal mechanism that it can be used for, or, it can also be used, in conjunction with your current internal mechanisms. And then also you can utilize that as one that I like is if your organization has a home health or hospice, sometimes those home health patients end up in the ER and the home health nurse may not be aware of that. So it could be that your home health may need access to that so they can monitor if their patients are in the emergency room, if they are being inpatient admitted elsewhere, because there's a lot of care transition work that goes into patients that have home health. And then, of course, there's organization or alerts from other organizations. So I recommend in that situation that you consider having your case management have access to this, and they can watch for patients. Especially what I think is, if somebody's transferred, okay, let's see when they get discharged from Stormont Vale. Then we want to make sure we have that follow up. They can be looking at that patient in looking them up in Caroline, checking their progress at that larger tertiary care center, and then knowing when they're going to go home and making sure that they get reached out to, or making sure if they qualify for swing bed, let's get them back here into our hospital for swing beds so we can get them rehabbed appropriately so they don't go straight home and perhaps end up being a readmission. So it really is a good process for everyone. Now, the other tiles, keep in mind, and I've mentioned this before, those are not updated daily. Those are updated about every 4 weeks or so because there's a large amount of data there. I recommend making sure when you go into these tiles, I would check that readmissions tile if you have a utilization review committee or whomever you have monitoring readmissions. Look in there, export that report, and see, do we have a common diagnosis that we are seeing? I had an organization where that common diagnosis was different types of heart failure. And so that was a great opportunity for improvement there, is that, the vast majority of readmissions were related to heart failure. And they were to their own organization. So, that's something that you can work on internally. The key is looking for those trends and then determining how you can then point your resources to work on those trends. The other is the high-risk patient tile, and that one is for patients who have 3 or more chronic conditions and 5 or more visits to the ER in a rolling 12 months. That's not just your emergency room, that's any ER visit. And what's really cool about the dashboard is it's not just using your information. It is absolutely everyone's information about that patient that we have received. So, you can run reports in your electronic health record, which is great, but it's not going to include that information that comes from other organizations that patient may receive care. With that said, that high risk, what you can do is go in and see which of your patients, maybe all, the majority of these high risk patients that fall in this panel all have asthma. There's a vast majority with asthma. There's a vast majority with hypertension. I'm always amazed when I look at these and the different organizations, that one organization, it's a huge chunk of hypertension, or in one, the most common chronic disease for this patient or for these patients was depression. So this can be used, and I highly recommend using this to look at strategies and take that to your leadership for strategic planning and resource allocation. When you guys are doing your community with your community assessment for your nonprofit status, this can help you with that as well. You can look at this, what are we seeing as most of our patient issues are, et cetera. So there's a lot of information here. We could really spend all day looking at all of this, but I really want you to think about how you can take one of these things and apply it at your facility and establish a workflow that can help you meet your quality and patient outcome goals. Next slide, please. And then finally, I realize like I said, we could spend all day digging into these, but if you want to know more about your interoperability status, like you said, a lot of folks don't know what their interoperability status is. Talk to your IT department or reach out to me and I can let you know what your connections are with KHIN and what's available for you. If you need workflow assistance for HQuick, or you can talk to your KHC QIA. I work very closely with them, and I can also set up times to work with you on that as well. And then we also do have training and supplemental job aid materials available on our website. But you can also give me a call and we can schedule or shoot me an email and we can schedule a webinar to work through that. I think HIE and these tools are a lot like algebra was for me in high school. I had to just keep learning about it, keep utilizing it, and keep just drilling into it. And then it finally clicked and I knew I could understand it better. So with that being said, I thank everybody for your time. It looks like we do have a couple of questions here. And if anybody else has any questions, feel free to, I think, type those into the chat. We are actually already connected to Lacey, but Lacey was taken over or absorbed by Midwest Health Connect, and we are connected to them. So when you go into KHIN, if we do have an open connection to Midwest Health Connect, so that information should actually populate. If it doesn't, you can look in the drop down, and there should be a Midwest Health Connect there, and you can look at that. But Lacey is, as Tammy was asking in the chat, is the KC Metro HIE, so like Children's Mercy and that information from the KC Metro. We do have a presence in the KC Metro, but some of those organizations are connected through Lacey and Midwest Health Connect. Are there any other questions?
Hey, Rhonda, I think there was a question from Donna McCarthy asking about the difference between a CCD and a consolidated CDA.
Correct. Yes, and that's a fun fact. A continuity of care document is created by an electronic health record, usually at the end of a visit. So when that encounter is closed, it gets sent, has meds, allergies, problems, procedures, and it's typically just going to be information from that organization. A consolidated CDA is going to be a massive CCD containing information about that patient from multiple organizations. So when you log into Caroline, you may see the CCDA and CONSA. That's because we have taken all those other CCDs and information and put them into one large document. So when you see CCDA, it's going to be a compilation of information from multiple sources rather than a CCD, which is typically just from one source. Any other questions?
Rhonda, there is some clarification. Do we understand that Lacey is the Midwest Health Connect?
Yes. Lacey was, Midwest Health Connect has joined with Lacey, and Lacey now falls under Midwest Health Connect. we don't have them separated out. So they are together. So if you access MHC, then you'll get Lacey info. Anything else?
Okay.
All right. Well, thank
Well,
you.
thank you, Rhonda. And you're right. It is like algebra. Every time I hear you talk or I work with you, I learn something new. So we really appreciate your time today, and thanks for some great information.
Thank you very much.
Okay, at this time, I'll turn it over to Eric for some data updates.
Oh, thanks. For some reason, I couldn't click my mouse to unmute myself just then. I apologize for that. Yeah, Rhonda, thank you for doing that presentation. KHIN's been around for a long time, and I feel like we're starting to get to a point after a lot of years of starting to see how we can use some of the tools that you showed, like the Health Query Insight tool. We're actually getting to a point where we can start thinking about how to use these tools and the HIE and the data in the HIE to do quality improvement. And we really haven't, KHC hasn't really done that very much in the past for a variety of reasons, but I'm really excited about, you know, the Alino Health project that we have going on right now that's going to take advantage of the HIE. And then some other ideas that we have that are starting to come up. Really excited about the possibility of starting to use the data from the HIE to do quality improvement. So thank you. Next slide. Well, I'll do my standard data update. Just as a reminder, all the data for a month are due at the end of the following month. The current refresh is from March the 7th. And our next refresh will be in April, probably around April 8th, because our data deadline for Compass H Quick is always on the 10th. I put in a note here, and this is actually very closely related to what Rhonda was just talking about, and how we can use data in the HIE for doing quality improvement. In one of the Compass communications that went out recently in the newsletter, they talked about something called a real report. And that real is a way of talking about, really the bigger concept is just data stratification. It stands for race, ethnicity, and language. But there's other things that you can look at, and actually that report does look at. The reports that IHC is producing with the data that they have access to on readmissions, which they actually link claims to get readmissions rates. And that's what they do in Iowa, Mississippi, and South Dakota. And that's the data that they're using for their real reports. And so they're basically just sending out stratified analysis, like some bar charts or some line charts, looking at readmissions rates stratified by different variables, such as stratified by men versus women, or looking at race and ethnicity, or looking at different kinds of age groups. In Kansas, our claims data system isn't linked. And for that reason, they can't do that report for us. We use QHI to look at readmissions. And in QHI, you guys enter in numerators and denominators every month. And that's the way we look at readmissions right now. But if that's the data you have, you can't actually look at your readmissions rate stratified by age, for example. And that is actually an important thing that we should all be doing with our data, sort of thinking about moving into a little bit more advanced analysis of our quality data. And so I just want to draw this connection that what we have with the KHIN and the Health Information Exchange in Kansas is access to a quality measurement tool that gives you a readmissions rate. It also gives you that readmissions rate with the Health Query Insight tool in such a way that you can look at those stratifications. You can look at your readmissions rate, not just over time, but you can look at it stratified by age or by different factors. So this is what we're diverging a little bit from what the other states in the Compass network are doing on readmissions. They're going to be focusing on their linked claims data set, and they're doing a report over there. But in Kansas, we have this tool, these health query insight tools. And if you're an HQuick participant in our state, you should have access to that tool. And so we encourage you to take a look at those stratified analyses that you can get from that tool. Next slide, please. Okay, really quickly, one new thing that's happened with our reports is we started for the first time, and I should have done this a long time ago, but we started taking a look at situations where data is in QHI. So that's good. We're meeting our data requirements if the data ends up in QHI. But remember that KHC transfers data from NHSN into QHI, and we do that every month, right before we do the snapshot and refresh. And so what we hadn't looked at before was how many situations there are where that system is sort of getting shortcutted. So you're not entering the data into NHSN, but instead you're just keying it into QHI. So the data is in QHI, but it's actually not in NHSN. If that's the policy that you have at your hospital, I think that's okay. We're not going to ask you to change that, but we just encourage you to think about trying to get that data into NHSN. And the big reason why is because for Iowa to be able to see that data, it has to come from their NHSN group. So if you remember at the beginning of HQuick, we sent out a request that everybody sign up for the NHSN group with IHC, and that's how they're evaluating that data. So there are actually some situations where we see that there's data in QHI, but IHC doesn't see it because it never made it into NHSN. So for that reason, we added a new shading. So on our data completeness reports, if you see in your report that you have some highlighted pink cells, those indicate that the data is in QHI, so good, but we don't see it in our NHSN exports. So we just encourage you to take a look at those and think about whether that data is actually making it into the official data system for infections, the NHSN data system. Okay, and if you have any questions about that, don't hesitate to email me or give me a call. Next slide. Another update, when you take a look at your run charts this month, and I think those reports went out last week, if you've been taking a look at the baseline rates and comparison rates, you may notice this month there's some situations where you used to have a baseline, but you don't have a baseline anymore, it's missing. And the reason why, I mentioned this on the webinar last month, but IHC and CMS for the HQuick project have been messing around with what the baseline rules are. And I'm not sure that this is set in stone what I have in front of you right now, but this is the algorithm that they're using currently. And so I implemented it in our reports this month for the first time. Before we were we looked at a little bit more recent data for the baseline, but this is actually what they're using. So the first choice for baseline is a 12-month period from January 2019 through December 2019. That's the official baseline period for HQuick. But if you don't have a full data set for that, the second choice is to look for a 6-month string of months where you have data from calendar year 2019. And so it'll find the most recent available 6-month period of time where you have data, and it'll take that as the baseline. If you don't have that, then it'll look for 3-month increments. So a little bit smaller time period, starting with January 2019, going all the way up to the last month before our official HQuick start month. So officially HQuick started on September of 2020. So they're going to be looking for baselines, and what you need is a 3-month period going all the way up through August of 2020. And if you don't have one of those, then you'll have a missing baseline in your report. So in case you notice that the baselines are slightly different, that's the reason why. Okay, next slide, Phil. Really quickly, this document is from QHI, from the Kansas Hospital Association. Just a plug for it, particularly if you're right now kind of bewildered about all the different quality reporting programs that there are in the state, and particularly if you're new or if you just want a refresher, KHA has put out a product here that's kind of a 101 for quality programs for critical access hospitals in Kansas. And I believe they're planning on updating it as there are changes to the program. So really recommend taking a look at that tool. Next slide. And finally, QHI, every month they do a training, and this month the training will be next Thursday on the 31st. And you can use that link to sign up. And I believe I'm passing the baton to Heidi next.
Yep, thank you, Eric. I just have a few educational updates to provide to everyone. Next slide, please. We want to thank everyone who has registered for our 2022 office hours series. Our next office hours is scheduled for April 27th at 10 a.m. Please make sure that you do have 10 a.m. on your calendars. Originally, when we started getting registrations, there was a little bit of a mix-up, and some people may have 1 o'clock. So please make sure that you have 10 o'clock for the next session. Next month's session will focus on improving sepsis through the patient's perspective. Sorry, I think I lost connectivity. Do you guys see me and hear me?
You're back, Heidi.
Okay. So next slide, please, Phil. Be sure to tune in to the next Quality Corner call on April 21st. This session will focus on building a meaningful patient and family advisory council. 3 Kansas critical access hospitals will share their experiences on their own PFACs and will also be available to answer any questions that you may have. The link to register for this event is available in your handouts. Next slide. On this slide, we've just listed some additional upcoming events. Links to register for these can be found on our website at khconline.org. Next slide. Are you guys still hearing me?
Yep, I am.
Okay, thank you. On March 28th, the Compass Network will host Jackie Conrad. She's going to give us her presentation on pressure injury prevention in 2022. The link to register is also available in your handouts. Next slide. And we also wanted to let you know about this initiative that's available to you from KHC and KDHE. We are still accepting applications for hospitals and clinics to join the Clinical Quality Improvement Project, Overdose to Action. This initiative is to prevent and decrease harm associated with controlled substances such as opioids and substance use disorders. Eligible hospitals and clinics are those that serve high-risk populations and have a need for education, training, policy development, and technical assistance around safe prescribing. If you have any questions about this program, please reach out to Mandy Johnson at KHC. Next slide. KDHE and KHC are also happy to announce a new 4-part antibiotic stewardship learning series that will kick off on April 7th, 2022. The event will provide practical implementation strategies for antibiotic stewardship in Kansas hospitals. Next slide. Once the webinar is over today, if you have any questions, please feel free to reach out to your quality improvement advisor, or we have provided a list of contacts to help get your questions answered. We do have a couple of minutes left, it looks like, so we do ask that you use your chat or Q&A features if you have any questions at all. And we do especially want to thank Rhonda for joining us today. As you leave today's session, you will be directed to a brief survey. We invite you to let us know what key takeaways you had from today's event. Next slide. And on behalf of our entire KHC team, we want to thank you again for joining us. Have a great afternoon, and we'll see you next month.